Hello, my name is Andrew McKeon. I am a director of the Neuroimmunology Laboratory and a professor of neurology and Laboratory Medicine and Pathology at Mayo Clinic. And I'm going to present to you today on laboratory diagnostics and autoimmune brain disease. So here are some disclosures. So I'm going to start by defining autoimmune neurology, how to recognize some of the different disorders, recognize key clinical features, the testing modalities that we use to test patients with autoimmune brain disorders, and then how to select evaluations. So autoimmune neurological disorders in general are caused by an aberrant immune response against particular antigens or epitopes, proteins in the nervous system that may be triggered in the context of cancer, that we call paraneoplastic, sometimes in the context of infection, parainfectious, or sometimes can be idiopathic. And these autoantibodies are unified by IgG markers detected in the serum or the spinal fluid. So how do these patients present? Well, in general, most patients present with a subacute onset of symptoms, so symptoms occurring over days to weeks, and the progression of these disorders tends to be rapid. Sometimes patients will report having had spontaneous improvements or remissions in their symptoms. The clinical course itself may be fluctuating. And so these are quite different from degenerative disorders or hereditary disorders that are more often insidious in onset and progressive, or at least if they are rapidly progressive, have a pretty clear trajectory over time. So while there are classical disorders such as limbic encephalitis, there can be other disorders where you can have just rapidly progressive cognitive decline, seizures in isolation, behavioral changes, and also there may be patients who will have kind of non-textbook clinical presentations. But the sudden onset and rapid progression tends to be a general theme. So these disorders can occur for a couple of reasons. Firstly, the patients may have a restricted version of the classical phenotype. So for example, some patients with limbic encephalitis may just present with seizures, and this has led to the concept of autoimmune epilepsy. Secondly, there are other patients who may have a multifocal neurological disorder. Thus, there are many potential permutations and combinations. For example, among some patients with limbic encephalitis, there may be patients who have accompanying spinal cord dysfunction known as myelopathy, or dysfunction of the peripheral nerves known as peripheral neuropathy, or sometimes even both. And this tends to occur more commonly, these multifocal disorders, in the paraneoplastic arena. So sometimes some anatomic and neurologic terminology is helpful to try to contextualize the utility of the different antibody biomarkers in different neurological phenotypes. So here we have the various levels of the nervous system that could potentially be involved. So starting from the top, we can have encephalopathy affecting the cortex, or seizures occurring at that level. The visual system, we can have optic neuritis or optic or retinopathies. We can have movement disorders of one type or another, either hyperkinetic or ataxic disorders. At the brainstem level, also ataxic disorders, double vision, dysphagia, myelopathies, spinal cord dysfunction or myelitis in your myelitis optica or MOG autoimmunity. And then peripheral neuropathies, either at the root level, the dorsal horn, which is very characteristic for a paraneoplastic sensory neuronopathy, and then also in the peripheral nerves themselves, in the muscles, and also at the neuromuscular junction. And so classical neuromuscular junction disorder is myasthenia gravis. So what are the risk factors for these disorders? Well, there can be, in some patients, particularly in young children who have not had any pre-existing medical history, there may be nothing found in terms of a risk factor, although there could be family history of autoimmunity in those folks as well. For some disorders like neuromyelitis optica or GAD65 associated autoimmunity, we can see a lot of pre-existing autoimmune disease, particularly in adults, such as thyroid disease, type 1 diabetes. We always ask about cancer history, smoking history, and family history of autoimmune disease or cancer. We don't tend to see the same neurological phenotype, though, replicated from generation to generation like we do in hereditary disorders of the nervous system. So what tends to unify these patients and their families is really the background of autoimmunity affecting other organs and more common autoimmune diseases occurring in those people. So how do we evaluate these patients further? Well, we try to define the neurological phenotype to start with, the history in terms of the acuity of the development of the symptoms, and the other historical factors that I mentioned, which can really help determine a level of suspicion for something autoimmune. If that's high on the list of suspicions, then certainly looking for other markers of autoimmunity in general, such as thyroid antibodies, connective tissue disease antibodies can be helpful, and then neuronal autoantibodies in the serum and spinal fluid. There are also other markers in the CSF that are more generically suspicious for inflammation. These are classically associated with diagnostics for multiple sclerosis, but can also be useful for autoimmune nervous system disorders like autoimmune encephalitis or autoimmune myelitis and so forth. So why do these disorders occur? Well, if we use the paradigm of a paraneoplastic disorder, as you can see here, there's a tumor, and then there's a vigorous immune response occurring against that tumor, and that results in the development of IgGs and various cell types, including B cells and T cells. In that context, you can see that there are these red effector IgG antibodies on the left, and these are kind of relevant in disorders such as NMDA receptor encephalitis, where you have an antibody that targets a receptor that's on the external surface of the neuron, and the antibody can react with that, can cause cross-linking, or there can be cross-linking of IgG across different receptors and then internalization of the receptor, or you can get activation of the complement cascade in neuromyelitis optica with the acroporin 4 channel antibody. On the other side, though, you have these green antibodies, which are generated often in the context of a cytotoxic T-cell mediated disorder, and we see this with a lot of paraneoplastic disorders or with autoimmune GFAP astrocytopathy. Nonetheless, these are still robust biomarkers in the lab, are not any less clinically specific for the disorders that we're trying to diagnose, although they do not have any pathogenic relevance. So in terms of the autoantibodies we can detect in the lab, breaking it down to these two broad groups, we have you can kind of see the common themes here. So for ANA1 or anti-Hu, we do occasionally see this in children. Children who have an underlying neuroblastoma may have ANA1 or anti-Hu antibody detected. But for the most part, we're talking about adults with small cell carcinomas. There are some other additional ones there that you can see, like the PCA1 or anti-Yo, that we've only ever reported in one child, but this is a relatively common one that we see in adults, in women with cerebellar ataxia who have either gynecologic or breast cancer. And then other exceptions to the rules there are thymoma, breast adenocarcinoma, and for the ANA3, the airodigestive carcinomas. The ones I've highlighted in yellow at the bottom are antibodies that have been discovered in more recent times that have varying levels of paraneoplastic association. All the ones in white on top, these are all really 70% positive predictive value or higher for an occult cancer, whereas the ones down the bottom we see cancer less commonly. So GFAP antibody, for instance, we probably find cancer in maybe about 1 in 5 patients. The neuronal intermediate filament light chain antibody is associated strongly with neuroendocrine carcinoma in more than 50% of patients. And then others such as septin-5 or adaptoprotein 3D2, we haven't commonly found cancer in those patients. Moving on then to the synaptic autoantibodies that I mentioned, these pathogenic antibodies targeting receptors and ion channels and water channels. except for the ones highlighted in yellow. For the most part, we don't commonly find tumors in these patients. So why do patients get these autoimmune diseases if we haven't found a cancer? Well, there's some instances of a post-infectious phenomenon, such as an NMDA receptor encephalitis post-HSV1 infection, occurring as a second phase of encephalitis. But for the most part, we don't actually know. We don't really know why people develop these disorders at that particular moment in time, what the particular trigger is. As you can see here, the ones that are most commonly associated with a tumor of one type or another is the NMDA, AMPA, and GABA B receptors, and also PCATR. So how are these antibodies detected in the laboratory? Well, there are a number of different methodologies that are used for doing this, and I've illustrated some of these here. And so one of the workhorses in the lab is this indirect immunofluorescence assay using murine tissue. So mouse tissue with patient serum or CSF applied, and then an anti-human secondary antibody with the fluorophore attached binds to the human already bound antibody, and you get these different patterns of fluorescent staining depending on what antigen or protein the IgG is binding to. So as you can see here, we have this cytoplasmic staining of the Purkinje cells in the cerebellum. This is very characteristic of PCA1 or anti-Yo. We then go on to a confirmatory step to determine the antigen for sure. And so for this situation, we use this line blot for anti-Yo, and we can use this particular line blot for detecting a number of different autoantibodies at the same time. We use some cell-based immunofluorescence assays like illustrated here for confirming other IgG profiles, such as for GFAP antibody here. And then there are some other commercial cell-based assays we can use for other conformational epitopes, like NMDA receptors, GABA receptors, AMPA receptors, LGI1, Caspr2. We don't commonly use ELISA assays, except for perhaps the ganglioside antibodies for autoimmune peripheral neuropathies. Radioimmunoprecipitation assays we still use in myasthenia gravis, diagnostics, and for Lambert-Eaton syndrome as well. So an example of a disorder whereby we detect an autoantibody reactive with an antigen expressed on the cell surface of a cell is the aquaporin 4 water channel that is highly enriched in astrocytes. But in our laboratory, we use a cell detection method that uses flow cytometry. So flow cytometry, most applications are typically for studying cell size and cell surface markers of blood cell populations, like detecting CD20 on B lymphocytes in patients treated with rituximab. But we also use it essentially the other way around for detecting antibodies. And so we have a cell population that expresses an antigen in particular, in this case, aquaporin 4. And we study two populations, one transfected with the antigen of interest, in this case, aquaporin 4, and the other consisting of untransfected cells. So this is an example of an aquaporin 4 IgG negative serum tested by flow. In the left panel, the healthy cells are selected by gating a population that does not include any debris. And this population is then analyzed for two measures demonstrated in the left panel. So green fluorescent protein on the x-axis, which is indicative of expression of aquaporin 4 by the cells. And then secondly, detection of aquaporin 4 IgG by the secondary antibody binding to the cells. And in this example, the secondary antibody binds to GFP negative and GFP positive populations in equal measure. And so we have a negative result. But in contrast, this is an example where we have positivity in the flow cytometry assay. And in this case, the GFP positive and negative populations are not equal. And the increase in secondary antibody signal and the amount of primary IgG in the cell surface is evident. And so you can kind of see this upslope here demonstrating a positive result with the positive signal in the anti-human secondary antibody. So then what we can do then is express that as a ratio, looking at the positive and negative populations, and come up with an IgG binding index. And so for aquaporin 4, this would be a binding index greater than 2, we've established as a good cutoff with high specificity and optimum sensitivity for neuromyelitis optica when we look at studies of clinical patients with this neuromyelitis optica disorder, where they have this aquaporin 4 antibody. And so these patients typically have either optic neuritis, myelitis, or both. And in some children, we see them present with encephalitis. So this is also used for MOG autoimmunity. The patients can have similar presentations, though typically not as severe and not always relapsing, but optic neuritis, myelitis, and in some patients in ADEM-like encephalitis. So then, what other types of disorders do we detect autoantibodies in, apart from the NMO phenotypes? Well, a common one that we come across is this limbic encephalitis, or more restricted forms of that disorder, like I mentioned earlier. You can see that there's kind of quite a wide range of autoantibodies that are detected in these patients. And you can see a list of these here. This is by no means complete, but it really just goes to illustrate the point that profile-based testing is really critical in these patients, because the sooner we treat the patients and the sooner we find out if there's any underlying occult cancer in their body, the better. So that's hence kind of our approach of kind of looking for autoantibodies by profile. There are also some non-limbic forms of encephalitis as well, and so NMDA receptor encephalitis will be an example of that. GABA A receptor encephalitis, where you have this multifocal pattern of enhancement in the brain associated with multifocal T2 signal abnormalities in the brain without enhancement and associated seizures. We also see patients with GFAP autoimmunity, like is illustrated here, where you have this radial pattern of enhancement in the brain. And the encephalopathy phenotype is different to limbic encephalitis. It can be accompanied by delirium, psychiatric symptoms, paranoia often. They don't have a kind of a classical amnestic sort of presentation like we see with limbic encephalitis. Neuronal intermediate filament autoantibodies we've also recognized as detected in spinal fluid is also associated with an encephalopathy phenotype. In fact, that's the most common presentation we see with neuronal intermediate filament antibodies. So another point that's worth bringing up here is the difference between serum and CSF testing. So for these particular disorders, CSF is the optimum specimen to detect the disorder, so it has the highest sensitivity and specificity. And that's not true for every autoantibody pertinent to encephalitis. So if we go back and take a look at LGI1 antibody, for instance, that is something that is more readily detected in the serum, as is GAD65 antibody. So again, for patients with suspected autoimmune encephalitis, we recommend testing both serum and spinal fluid. So then autoimmune cerebellar ataxia. So this is another form of encephalopathy, if you will, which is focused on the balance center of the brain, resulting in dysarthria, speech disorders, incoordination, gait disturbance, and vertigo. It almost universally has had a kind of a bad reputation as something having a poor outcome because of this particular disorder, PCA1 or anti-Yo, which is the originally recognized form of this autoimmune ataxia. But there have been other antibodies recognized over time, less common than PCA1, but some of these patients have a better outcome and less commonly have cancer. So overall, the disease categories to consider in patients with autoimmune neurological disorders are the encephalopathies, dementias, epilepsies, movement disorders, myelopathies. I haven't gone on to talk about peripheral nervous system disorders today, but neuropathies, myasthenia gravis and Lambert-Eaton syndrome, and myopathies. And so we take a profile-based approach depending on what the phenotype is, what the doctor finds on the history and the exam, alongside the other factors that would make one suspicious for an autoimmune cause. What are the actual neurological findings on history and exam? And what is that ultimate phenotype? And then that would help select a profile of antibodies for testing for some of the CNS disorders, testing both serum and CSF, and then for the peripheral nervous system disorders, just testing serum. So for neuropathies, myasthenia gravis and Lambert-Eaton syndrome, and myopathies. So here's an example of kind of a montage of what that might look like, depending on what you're testing for. And we recognize that in adults, there a profile of antibodies associated with small cell lung cancer primarily that aren't relevant to children. And so you can sort of divvy it up that way as well between children and adults. And so you can see kind of the analytes across the top in terms of the different antibodies and then the different evaluations along this axis here. So in summary, these autoimmune neurological disorders, including autoimmune CNS disorders and CNS autoimmunity in general, is important to consider. These are overall rare disorders when you take them individually, but collectively speaking, when you're kind of on a general neurology hospital service, either adult or pediatric, there's usually a couple of patients on any service where these disorders are being considered. As neurologists, we like to consider these disorders also and to not overlook these disorders because they're potentially treatable and they may be indicative of occult cancer. And clues may emanate from the history exam, as I mentioned. And then for cases where it's suspected, serum and or spinal fluid evaluations may be appropriate for IgG antibodies. And then in some circumstances, we may find that the patients are seronegative, but we still have a high level of suspicion. And that's particularly true in children, where up to 50% of children may actually be IgG negative. But there's still enough between the history exam, other inflammatory findings, and the MRI imaging or CSF where we may ultimately confirm the diagnosis by initiating a trial of immunotherapy and looking for a response to treatment. Okay, well, that's it. Thank you very much.
Thanks so much, Dr. McKeon. And I understand that you are available to answer questions. We do have a few minutes left. Two that are somewhat related are, which tests would you recommend for the PANDAS syndrome? And also related to that, if you've done a lumbar puncture and the immunologist tells you they found nothing of significant, what sort of tests should they have done to rule out autoimmune encephalitis, PANDAS, PANS?
Sure. So I suppose that kind of the world that I'm kind of operating in, we don't specifically do testing in the area of PANDAS and PANS, and there are other labs that do that. I guess that the one antibody that has kind of caught my attention that we're a little bit behind the curve and kind of really starting to look at is the D2R receptor antibodies and their role in a variety of different neurological and neuropsychiatric disorders in children. But we've established a collaboration at this stage to start to look at that. I think that in general, I mean, I think that in terms of looking at the spinal fluid, I mean, it's not kind of I suppose kind of in terms of how I presented, I'm trying to kind of paint a picture for the patient rather than necessarily saying that there's kind of one biomarker or one particular factor that's very specific. We kind of try to look at the kind of the overall story and the spinal fluid findings and so forth. But if that kind of came up, I mean, you'd certainly like to know, was there any evidence of, IgG synthesis, elevated IgG index, elevated oligoclonal bands. But, a normal CSF certainly doesn't rule it out, rule out an autoimmune disorder. So when I talk about autoimmune disorders, of course, I'm talking about kind of things where we can kind of measure very particular IgG biomarkers and where there's been kind of this rapidly progressive course. But I think that, we always just try and keep an open mind. I think part of the problem, though, is with trying to assess response is often the most difficult thing, I think. And certainly something I've struggled with as kind of an adult neurologist when I'm asked to evaluate children. But, in adults, it's kind of, we, can kind of generally, do some, measures like, okay, they have a normal EEG to begin with, and then the EEG normalizes, or they have a substantial improvement in their bedside neurocognitive exam or the neuropsychometric testing. But we kind of try to go for those kinds of measures as outcomes, because I guess everybody kind of feels a little bit brighter on steroids. And, it's always kind of a little bit of a challenge to bring about some kind of objective interpretation. But we do use that to make the diagnosis quite a lot of the time.
Great, thank you. And oops, no, my phone went to sleep. There's one more. Would you consider doing this workup in a typically developing 2-year-old child that shows sudden regression skills?
Yeah, in fact, those have been kind of the few memorable cases I can think of over time, where the story kind of went that it was, kind of a developmental regression kind of story, but it occurred kind of at an astonishing rate, and really kind of over the course of a week or two, and a couple of and that's, I guess, how they kind of came to kind of to my office to see, or to my service. So I don't really have a kind of a big end of other kinds of patients, because I don't see patients with autism in general, but the ones that I did that have come to attention, we found some autoantibody markers like VGKC, voltage-gated potassium channel complex antibody markers, where the kind of the more specific ones, LGI1 and caspr2, were negative, but the titer was kind of high. The story was quite compelling, but unfortunately, by the time we saw the patient, it was like a year later. So it was kind of like, how do you really go back and establish what happened there? And it's really at that point, unfortunately, the response to immunotherapy, in our experience at least, doesn't tend to be all that great, particularly for CNS stuff. Myasthenia gravis, Lambert-Eaton, autoimmune dysautonomia, those kind of more peripheral nervous system things, we seem to get better responses to the antibody-mediated things. But in the CNS disorders, it's a lot more difficult. But those, if anybody wants to collaborate, those would be the patients I would think of, if we were to look, consider looking for a kind of a unifying IgG biomarker in a subset of patients, where you might say, okay, this is this is kind of presenting with features of the autism phenotype, but where similar to the other ones that are kind of known about out there that I've discussed today, where there's just that rapid progression, where that's kind of a very kind of big feature of the story.